Hey guys, welcome back to my channel, The ENT Resident. Today I'll be continuing our series on tonsillectomy, and today our topic of discussion is going to be about the complications of tonsillectomy. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. How do we classify complications of tonsillectomy? So we can classify this into immediate complications and delayed complications. Well, first let's talk about the immediate complications. The first complication here is primary hemorrhage. Now, there is a whole new topic that I'll be definitely discussing separately in a video where I'll be talking about post tonsillectomy hemorrhage, which there are three types of hemorrhage: primary, reactionary, and secondary. And I'll be talking them about them in more details over there. But here I'll just like skim over a little bit. So, what is primary hemorrhage? Primary hemorrhage is the hemorrhage that is occurring at the time of operation. And the usual causes over here could be an improper ligation or a cauterization of vessels, slippage of ligature, injury to the tonsillar branch of facial artery, or any other nearby vessels. And this can be easily controlled by pressure, ligation, or electrocoagulation of the bleeding vessels. This is about primary hemorrhage. Second complication is reactionary hemorrhage. Now, this is the hemorrhage that you see within 24 hours of the surgery. And more commonly, this is seen within 6 to 8 hours of the surgery. The common causes over here could be either due to slippage of ligature or due to presence of clot. And the management over here would involve removal of the clot, application of pressure, or vasoconstrictor. This is about reactionary hemorrhage. Next is surgical trauma. Now, during the time of surgery, a lot of structures can get injured. There can be trauma to the lips, tongue, tonsillar pillars, posterior pharyngeal wall, and this usually happens because of faulty placement of the tongue blade when you are placing the Boyle and Davis mouth gag. Or burn injuries to the tongue can happen if cautery is being used. Management of all of this usually involves a proper placement of the mouth gag, and that will prevent the development of these complications. Second surgical trauma is edema of the uvula, and this happens because of two reasons. One is excessive manipulation during the time of surgery of the uvula, and second is when you end up excessively removing the anterior tonsillar pillar. In that case, the patient will have edema of the uvula in the postoperative period. Management of this involves using injectable steroids. Last is injury to teeth. If you see a tooth is missing at the end of your procedure, then what do? You'll perform a chest x ray immediately to rule out the aspiration of the tooth into the tracheobronchial tree. And when you locate the position of the tooth, then you remove the tooth with the help of bronchoscope. So, this is all the surgical trauma that can happen during the time of surgery. Next complication is aspiration. Now, aspiration of what? Aspiration of the blood and secretions into the lower airway. Now, there are multiple ways that we prevent this, and this is again a very common question that is asked during the time of your practical exams. How would you prevent aspiration? What are the different precautions taken? First of all, starting right from the position of the patient before you even perform the surgery. So the patient is placed in Rose's position, where the head is kept low with an extension at the atlanto-occipital joint. This position will help you in preventing aspiration. Second, the use of cuffed endotracheal tubes. Third is the placement of throat pack on either side of the endotracheal tube before you start the surgery. Fourth, after you have completed the surgery, the surgical sites and the nasopharynx should be properly irrigated with saline and remove any clot and tissue that you find over there. Lastly, post-operatively, we'll place the patient in a left lateral position to drain out all the blood and secretions. So these are the different ways that the different precautions that you can take to prevent aspiration in a post-operative case of tonsillectomy. Next complication is airway compromise. Now, what happens here? This can end up occurring intraoperatively due to either malposition, kinking, or compression of the endotracheal tube. This can also occur due to pulmonary edema. If it has happened due to pulmonary edema, in that case, you treat it with diuretics, CPAP, which is continuous positive airway pressure, and ventilatory support if necessary. Next complication is airway fire. Why does airway fire happen? This can happen when you use diathermy in the presence of a leakage of anesthetic gas. Now, a way to prevent this is to place a wet gauze around the endotracheal tube. So that will prevent the contact between the diathermy and the leaked anesthetic gas. And in case the fire has actually happened, in that case, what you need to do immediately is cut off the supply of anesthetic gas immediately and pour the saline that you have in your operative table into the oral cavity immediately. That should take care of the airway fire. Next complication is dehydration. This usually results because patient may not end up eating because of the pain that they are experiencing, and this is very common in younger children. So, a way to manage this would be to ensure proper hydration of the patient both intraoperatively and postoperatively. Next complication is facial edema. Some patients are seen to get facial edema postoperatively, particularly around the eyelid area. Lastly, surgical emphysema, which is a very rare complication, and this can occur due to injury to the superior constrictor muscle. So, these are the 9 immediate complications of tonsillectomy. Next, let's talk about the delayed complications of tonsillectomy. Starting with secondary hemorrhage. Now, secondary hemorrhage is the hemorrhage which is occurring between 5th to 10th post-operative day. And the likely cause over here is usually sepsis or infection. So, this can be managed with the help of IV fluids and antibiotics. Sometimes even blood transfusion may be required. Next complication is infection of the tonsillar fossa. Now, this is a very common complication that happens if you end up performing a hot tonsillectomy. That is, during you are performing tonsillectomy during the time of acute infection. And if you also, there is improper sterilization of the surgical instruments used. This infection can end up in leading to parapharyngeal abscess development or even otitis media. And if the child develops halitosis, you should definitely start the child empirically on metronidazole along with penicillin group of antibiotics for a period of 7 to 10 days. Next are pulmonary complications. Now, how can pulmonary complications develop? This may result due to inhalation of blood or tonsillar tissue, and that can lead to resultant collapse or pneumonia or lung abscess to develop. Now, the respiratory compromise can also occur due to pulmonary edema, which is commonly seen in children with a history of prolonged airway obstruction. So, you treat all of this in ICU. You treat the case of pulmonary edema in ICU with diuretics, CPAP, and ventilatory support. Next, you can end up causing scarring of the soft palate and pillars due to the injury caused intraoperatively. Next, we can have tonsillar remnants. Why does tonsillar remnants remain? This can be due to incomplete removal during the time of surgery, and this may lead to repeated infections, necessitating its complete removal during another second stage procedure. Sixth complication is a hypertrophy of the lingual tonsil. Now, this is a very late complication of tonsillectomy, and this occurs usually compensatory because of the loss of palatine tonsils. So, this usually happens in a child of a very young age, maybe 3 to 7 years old. Around that time, there is a compensatory hypertrophy of other lymphoid tissue seen after you remove the palatine tonsils. Next complication is pharyngeal stenosis, which can occur due to inflammatory process, and the treatment involves injection triamcinolone and lysis of the adhesions that has formed. There can also be velopharyngeal insufficiency, especially in cases of cleft palate. That is why cleft palate is a contraindication for performing tonsillectomy. Last complication is something that is known as Grisel Syndrome. Now, this is a very rare, very rare, but a very serious complication of tonsillectomy, where basically there is a non-traumatic atlantoaxial joint subluxation happening. This occurs due to post-surgical inflammation and hyperemia of nasopharyngeal and cervical region, which leads to the laxity of transverse ligament of atlas. In this patient will complain of neck pain and torticollis, where there is restricted neck movement on the side. And more commonly, this condition can develop in cases of collagen vascular disorders or a patient of Down syndrome. And there's a higher risk seen of Grisel syndrome in case of adenoidectomy rather than in tonsillectomy. So these are all about the complications of tonsillectomy. In my next video, I'll be talking in details about post-tonsillectomy hemorrhage. So I'll see you in my next video. Thank you.